Hi there, my name is Josh Timewell, and this is my part 2 of the oral presentation assignment number 1. So, a super quick breakdown of the presentation today. I'm going to talk about the topic choice, my article that I chose, why I chose it, dissect the article a little bit and tell you about it, the analysis, and then the conclusion. So, I chose topic number 4. Which was the case study involving Zhang, who's come to Australia. He's got some poor English speaking abilities, and he's having anxiety, loneliness, and depression. So he's been recommended to see a psychologist. The question that relates to that is evaluate the importance and usefulness of cross-cultural training for health professionals. Now, I had 3 articles to choose from part 1 of the assignment. The first one was regarding some medical residents in a hospital in California, and they were required to self-assess for their preparedness and skillfulness in cross-cultural care. The second was a study that involved parents and the use of analgesics for children, how the ethnicity and language changed their misconceptions. And the third was a maternity study for immigrant Muslim women and the way that they were treated culturally in their hospital during their pregnancy. I chose the third. They can't understand it. Maternity health and care needs of immigrant Muslim women in St. John's, Newfoundland. The article was published by Sylvia R. and Diana G. I won't try and pronounce the last names. It was published in the Maternal and Child Health Journal in 2008. Now, there are a number of reasons why I chose this article above the others. Firstly, it does involve direct cross-cultural competency, which is based on personal experience. Now, it is a very subjective thing to measure, but in the same way, it is similar to the case study, which was, again, a very subjective thing. It's also very relevant today with the many debates and things that are happening with Muslims, so it contributes to and explores the preconceived ideas of Muslim people and the way that they feel they are being treated in this particular circumstance. Now, a little bit of background for this particular study. Muslim women are the most fertile in Canada at an average of 2.41 children per woman. It also saw the first study into this particular issue in Newfoundland in Canada, where the Muslim population was in fact increasing. Muslims are also not homogenous, which means that they do come from different ethnic groups, although they do share the same religion. The area also had quite a high attraction to immigrants and drew a lot in, but a very low retention rate at only 36%. Muslim immigrants in particular were also at a very low socio-economic level. They lacked understanding in medical fields, including pregnancy in this case, and an English study of a similar case showed that because of the lack of understanding, there in essence was a higher risk of mortality for infants. Now, the aim for this particular study was basically to determine any cultural differences that could have a potential effect on their patients' experiences. The hypothesis was based on prior research, and whilst it didn't jump to any conclusions, it did estimate that Muslim women were minoritized in culture. They expected to see a very similar image of the broader culture in the healthcare industry as well. Now, for the method, the sample involved 6 immigrant Muslim women who had given birth at the St. John's Hospital between 1995 and 2005 to 9 children at the hospital. They had given birth to 18 children total, and they all spoke English. The research involved 15 open-ended questions, which were interviewed mostly at their own homes, so the women were able to attend to their children. 1 woman out of the 6 chose to have her interview out of home. The interviews went for around 2 to 3 hours. Now, because each woman was asked 15 questions, there was quite a lot of information present in the report, so I've tried to sum up most of the key results here. They basically said that they were not given enough information and that what they did get had to be asked for. It was also quite difficult for them because they were newcomers to the country for the most part, so it meant that there was quite a large language barrier. Most of the programs that they had been offered to attend pre-birth were designed for husbands to be involved, which went against a lot of their religious beliefs. Now, it was okay for the most part to have a male physician involved during the labour, but they preferred to have a woman involved. It was a last resort to have a man. There was also issues with privacy and, in particular, quiet places where they were able to pray. Similarly, there was concerns about the food that was offered during hospitals, whether it was halal or not, so that was not taken into consideration. Finally, they were not given information and were not assisted with male circumcision, which is a compulsory aspect to Islamic beliefs. Now, after having gathered this data, the analysis was broken into two stages. The first stage was broken into phases, including pregnancy, labour, in hospital, and at home. That allowed them to very easily group each piece of information into each aspect and each part of the pregnancy stages. From there, they developed some meta themes, which also involved barriers to accessing healthcare. These included language barriers, religion, and times when insensitive comments were made. Having run the interview answers through the two main stages, the researchers were able to develop meta-themes, which, whilst not directly mentioned by the women, were undertones throughout their answers. They involved not being able to access appropriate content, weak social support, for example, difficulty accessing mothers' groups, presence of men in prenatal education, which often went against religious beliefs, and medical advice that suited nutritional needs, for example, advice about fasting during pregnancy and breastfeeding, and doing so healthily for the child. Now, whilst brief, the conclusion determined that the women felt as if they had been discriminated against. They also suggested that not only was it up to the relevant authorities to create change, but it was also a responsibility of Muslim women to be active within the community and partner with those relevant authorities. Finally, they recommended that healthcare providers have the responsibility to ensure their staff are up to date with cross-cultural values and update their education as the times change. Now, like every study, there were some limitations, the first of which was the sample size of just 6 people. Now, the researchers did say that they believed they had reached a point of saturation where, after about 6 people at a detailed interview stage, the meta-themes begin to emerge. Similarly, the participants may have been more culturally non-diverse than expected. Of course, they did share the fact that they were Muslims. However, given a lot of the information was withheld, it's difficult to know exactly where each woman was from and their background. It was also mentioned that during the interviews, some of the women were distracted whilst looking after their children. Now, that meant that a lot of the questions had to be repeated, which may have also meant that some of them were misunderstood. Finally, all of the women did speak English to some extent, which may have not been an accurate representation of the Muslims in the area if many of them did not speak English. Now, the study was quite open with this, saying that it was too expensive to hire a translator, but it may not have been an accurate representation of the demographic. And with that, that is the end of my presentation. Thank you very much. I hope you enjoyed, and this is the reference for the article for those interested.